So my name's Andrea. I'm a genetic counselor at Children's Mercy in Kansas City, Missouri. I represent one of 4 genetic centers in the state of Missouri that participates as a referral center for newborn screening. So I'd like to present to you, these are my disclosures, our data in the state of Missouri over the past 2.5 years with doing newborn screening for 5 lysosomal storage disorders. So just to take you back a little bit and kind of explain the history in Missouri, so here are the 4 centers. I'm here in Kansas City. There's a center in Middle Missouri at Women and Children's Hospital, and there's 2 centers in St. Louis Children's and Cardinal Glennon. Laws were passed fairly quickly back in 2008, 2009 to include 5 lysosomal storage disorders on our newborn screening panel in the state of Missouri. It was an unfunded mandate. We did get a few years to get it set up, but then in 2012, in August 2012, we were not fully set up to begin newborn screening due to it being an unfunded mandate. So we did enter a contract in with the state of New York. So the state of New York has been providing newborn screening for the state of Missouri for Krabbe disease since almost 3 years now. Missouri recently acquired technology to utilize a fluorometric assay to begin newborn screening for the GAL-C enzyme for Krabbe disease, and with second-tier DNA testing looking for the 30 kb deletion in the GAL-C gene only. And we will be breaking away from New York at the end of this month. But we'll talk a little bit about that data. Then in January of 2013, the state of Missouri, utilizing a microfluidic platform, a digital microfluidic platform, began screening for MPS I, Pompe, Gaucher, and Fabry disease. And this is all still in pilot phase. We have not gone to live screening yet, but we plan to go to live screening for these 4 disorders later this month. This is pictures of our machines in the laboratory. This is the standard microfluidic platform. 4 machines make up a workstation. We have 2 workstations in the state of Missouri run by this little computer. It's a plug and go method. It's populated with these digital cartridges where you can load, and we'll go through that in the next slide. But this is a picture of our fluorometer and the incubator for the technology we're utilizing for newborn screening for Krabbe disease. So as you can see, not very big equipment, kind of you can tuck it nice and easily into your lab. So the workflow for how we do newborn screening in the state newborn screening lab, machine that punches the dry blood spot samples. We have a 30-minute extraction period and a 5-minute loading period. And then the samples are then run on the machine for about 2.5 hours. Total start to stop time is about 4 hours using the digital microfluidic platform. Our state lab has 2 scientists working on 2 different workstations of 8 instruments. There's 48 sample wells on each cartridge. 10 of those wells are used with control samples, 2 blanks, 4 calibrators, 2 low controls, and 2 medium controls. And then there's 38 patient samples loaded onto each cartridge. So times that by 8, we can usually handle what we get in Missouri. Our birth rate's about 80,000 a year. And like I said, sample punch to enzyme activity results is about in 4 hours. So how we do referrals in the state of Missouri, every state's a little bit different about who is contacted with abnormal newborn screens. Since Missouri contracts with one of 4 centers, the state contracts with us to provide follow-up for newborn screening as the genetics providers in the state of Missouri, but the primary care provider is also notified. So we do work together to identify these patients in a timely manner. So from the time that we get contacted to the time of finding these families, there's sometimes a little grunt work that has to be done to find these families. They sometimes don't answer the phone if it's a blocked number or an unknown caller. And sometimes we do have to go to the length of sending a social worker or sometimes even a police officer out to the home if they're not responding to our request to call us back. This is a screenshot of kind of to date, as of the end of May, what we've seen for the 5 different disorders, and we'll focus on Pompe disease. But like Dr. Wilcox said, the microfluidic platform was a fairly new assay. So the aggregate number over the last almost 3 years is probably higher than what new states coming live would see with newborn screening, because we kind of had to start from scratch with everybody to set reference ranges. So as you can see, and we'll go into the Pompe data, and if anybody has questions on the other disorders, feel free to come find me today. I'm happy to discuss with you. Sharmini Rogers is here today too, and she'd be happy to discuss. Utilizing the microfluidic assay, our positive predictive value for Pompe disease is around 20%. That means of all the samples, we utilize this number as a genetic counselor that 20% of the time this test may show what we're looking for, 80% of the time it shows a false positive. These numbers are subject to change based on the numbers of samples that we get referred back, as well as the incidence of the disease. The more prevalent the disease, the more likely your positive predictive value is going to be higher. The more rare the disease, the more likely your positive predictive value is going to be low. Disease incidence kind of caught us off guard in Missouri. We didn't quite anticipate the incidence of Fabry to be so prominent at 1 in 3,500 with the current diagnostic or disease incidence in the literature reported as about 1 in 40,000. Specifically for Pompe disease, we've seen, and this aggregates late onset Pompe and infantile onset Pompe together in about 1 in 12,000 babies compared to 1 in 40,000 reported in the literature. And for the rest of the other conditions, they've fallen in line with the predicted disease incidence. When we receive a referral for Pompe disease, we set a lot into motion pretty soon. We like to get these babies in within 24 hours of receiving an abnormal newborn screen. When we do get them into clinic, usually we have them seen by a geneticist and a genetic counselor. We go over what newborn screening is, what Pompe disease is, to educate the family. We obtain a repeat newborn screen. We obtain confirmatory GAA enzyme activity with reflex to DNA testing if the GAA enzyme is low or borderline. We obtain a urine sample for urine hex4 analysis. Locally, we do CPK, CKMB, liver function studies, and an LDH. Optionally, providers might do a basic metabolic panel, especially if the baby may look sick or have cardiac manifestations, to look for acidosis. And then we have the baby seen in our cardiology clinic for echo and EKG. Optional chest x-rays can be done dependent on the provider. So what we've seen, I've got it highlighted here, are numbers as of May 31st. Dr. Rogers is going to be talking about more updated numbers tomorrow. So as of the middle of June, we've actually had 102 referrals for Pompe sent to one of the 4 centers in Missouri. We've had 17 of those babies confirmed positive to have Pompe disease. 6 of those babies have have infantile onset Pompe disease. Of those, 2 of those 6 actually have a non-classical form. Their genotype predicted a late onset Pompe disease, but they actually presented in the first year of life, so they were started on treatment. All 6 of these babies with infantile onset Pompe disease were quickly started on enzyme replacement therapy, and all are doing well at this time. One of those babies was placed on weekly dosing due to lack of quick effect on ERT due to pretty significant cardiomyopathy, and none of the babies were CREM negative. We now actually have 11 cases of late onset Pompe disease. None of these babies are on treatment. All are being watched closely by their geneticist. One of the families, 2 of the older siblings, were also tested positive for late onset Pompe disease. And then we have 3 babies that were identified with a genotype of unknown significance. 2 out of 3 of those babies actually have GAA enzymes that are in the affected range, so we're trying to monitor those babies accordingly. And there's been 16 cases of pseudodeficiencies identified in the state of Missouri. We know that in the Asian population, there is 2 mutations on 1 allele that occurs more frequently in the Asian population, leading to a pseudodeficiency of GAA. We have a large Pacific Islander population in Missouri, unbeknownst to us when we started screening, but we found them. And a lot of our referrals are coming from 2 large populations of individuals of Pacific Island descent. Now, we do have 3 babies that we have identified who are carriers of this pseudodeficiency allele, who also happen to be carriers of either a known pathogenic mutation or a variant of unknown significance. And we're not exactly sure if those babies are expected to be at an increased risk for disease manifestations in their life. None of those babies have a GAA enzyme that are in the affected range, but they are somewhat borderline on their enzyme activity. And again, all of these babies are healthy, and we've asked their primary care providers to keep a close and watchful eye on them. And these are just some of the references we use for medical management guidelines, since I did not want to get into medical management. And our first 6 months of data from newborn screening for lysosomal storage disorders have been published. There are some guidelines that will be coming out in the literature for updated medical management guidelines for Pompe disease, taken into account newborn screening into those guidelines. These are a lot of people work together to make newborn screening happen, and this is a small list of the greater individuals who actually work with us on this. So thank you.
Why don't we save questions till the end?